Wait. वो नहीं है ना, नहीं जैसे दिखाई देते थे। अब आओ। हाँ ठीक है मैडम, कर अब उसको कैसे करोगे? F5, F5, F5.
Good afternoon everyone. Today we are going to see the CVS case based learning. So we will be seeing the prescription writing based on cases, and after that we will be going through the drug interactions. So before going to the case 1, so in the prescription writing, what all you have to include is, you have to include the patient details, then the doctor details, then the diagnosis of the patient, then the treatment. These are the things you have to include in your prescription. So first we will go to the case number 1. 58-year-old male working as an auditor. I can continue now. 58-year-old male working as an auditor having a weight of 90 kg presented to the medicine OPD with symptoms of angina pectoris. On examination, he was found to be hypertensive. His BP is 160/98 mm mercury, and his laboratory investigations showed deranged lipid profile with increased total cholesterol, LDL, and reduced HDL. So you have to write the prescription to manage such a patient. So here what are the points you are noting down? It's a 58-year-old male, and he has the symptoms of angina pectoris, like he is presenting with chest pain, and you are examining him, and you are seeing that he is having a hypertension, and you are ordering him laboratory investigations, and it shows deranged lipid profile. So you have to write a prescription to manage this patient. So in the prescription you have to write your doctor's particulars, that is your particulars, like your name, then your affiliation, then your phone number, then your registration number. Then for is for patient, so you have to write the patient details and patient where from the patient is. Then you have to also include the diagnosis in the prescription writing, and you have to put a date also, and after that you have to write the treatment chart. And this is like, this patient is managed with tablet atorvastatin. You have to write the drug name, then you also have to write the dosage. The atorvastatin 10 mg, HS is the route of like frequency of administration, and tablet is oral, so route also you have to write. Then tablet metoprolol 100 mg BD, then tablet ecosporin 75 mg plus tablet clopidogrel 75 mg, then tablet telmisartan 40 mg OD. Then finally you have to write your name, and you have to sign it, and you have to put a stamp. So this prescription is actually incomplete. In the next slide I will show you the complete prescription, like how it should be. So you have to write the particulars. The patient is having hypertension and coronary artery disease. He is having symptoms of angina pectoris. So tablet atorvastatin is given. Atorvastatin is a HMG-CoA reductase enzyme inhibitor, and it reduces the cholesterol synthesis. And you have to write like this, like tablet atorvastatin 10 milligram and dispense 10 tablets, and he has to take one tablet at bedtime. So because the enzyme activity is higher at the night time, so we are administering atorvastatin at night time for control of dyslipidemia. This is not this is wrongly written as high blood pressure. Actually make a note of it. Atorvastatin is given at bedtime for the control of dyslipidemia, and it decreases the total cholesterol levels. It actually decreases the synthesis of cholesterol by inhibiting the enzyme in the cholesterol pathway, which is HMG-CoA reductase. So you are giving atorvastatin 10 mg, then you are giving metoprolol 100 mg, dispense 20 tablets. So why you are giving metoprolol? Metoprolol is a beta blocker, and it decreases the heart rate, and it decreases the oxygen demand to the heart, and it decreases the workload of the heart. It decreases the heart rate. It also decreases the blood pressure so patient has to take one tablet of metoprolol 100 mg twice daily after food for control of heart disease. Then tablet ecosprin. So ecosprin is it's an antiplatelet drug. So ecosprin 75 mg plus tablet clopidogrel 75 mg OD. This is we are giving to it's an antiplatelet. It inhibits the platelet aggregation, and it should be taken once daily for the control of heart disease. So ecosprin and clopidogrel in combination is a antiplatelet action, thereby preventing the further recurrent episodes of angina pectoris. So it should be taken once daily for the control of heart disease. Then finally he is being prescribed telmisartan 40 mg once daily. So telmisartan is an antihypertensive. So we have seen that patient is having the BP of 160/98. So we have to also control the hypertension. So hypertension is also associated with the adverse cardiovascular outcomes, and it also increases the complications of heart diseases, and patient is having angina pectoris. So we have to control the hypertension to prevent the further episodes of angina pectoris. So here we are giving telmisartan, which is an angiotensin receptor blockers. Telmisartan 40 mg once daily, and it should be taken one tablet once daily for the control of hypertension. Here it is wrongly written as control of heart disease. Actually telmisartan is given to control the hypertension. So if we see, so we have addressed all the disorders whatever the patient is having. So patient is presented with symptoms of angina pectoris, where he is having hypertension. So we have prescribed telmisartan 40 mg once daily. So we have addressed hypertension. Then his laboratory investigation showed deranged lipid profile with increased total cholesterol, LDL, and reduced HDL. So we have addressed the dyslipidemia by prescribing atorvastatin 10 milligram at bedtime for the control of dyslipidemia. Decreases the cholesterol synthesis and increases the expression of LDL receptors in liver. So thereby it enhances the uptake of LDL and decreases the LDL levels in the blood. So we have addressed dyslipidemia. Then we have also addressed the angina pectoris. To prevent the recurrent episodes, we are decreasing the workload of the heart, and we are decreasing the heart rate by giving metoprolol. Metoprolol takes care of the tachycardia and cardiac workload and oxygen demand to the heart, and we are also giving antiplatelet action, ecosprin and clopidogrel to prevent further recurrent episodes of angina pectoris. So next case is Ratan Sharma is an information technology professional working in MNC for the past 15 years. He resides at house number 21 South Extension, Part 1, New Delhi. He is a 45 years old, married and has 2 kids. and he has undergone a routine checkup, and he has been diagnosed with type 2 diabetes mellitus and also had dyslipidemia. He was advised diet control and moderate exercise. 3 months later, investigations revealed the following: HbA1c is 8%. So 8% of HbA1c shows a poor control of diabetes. So for to attain adequate control of diabetes, HbA1c should be less than 6%, and his fasting blood sugar is also deranged. It is 155 milligram per deciliter. It should be around 100 to 110 milligram per deciliter, but here the patient is having 155, so fasting blood sugar is elevated. Then LDL is also elevated, 161 milligram per deciliter, and total cholesterol should be less than 200, but here the patient presented with 250 milligram per deciliter. So you are his treating physician, and you have to prescribe drugs to combat all the increased sugar levels and elevated cholesterol levels. You have to keep the sugar levels and cholesterol levels under control for the patient. So what will you advise? So again, here you have to write your the doctor's name and his affiliation, his registration number, then the date, then the patient's name, age, sex, weight of the patient if needed. Then sometimes to calculate the dose you need the weight of the patient, then the patient's address, then you have to write the diagnosis of the patient. So this patient is diagnosed with type 2 diabetes mellitus and dyslipidemia. How can you say that this patient is having type 2 diabetes? Because it is given in the history, and also like type 1 is from childhood. It is present when the from the childhood. If the patient is having diabetes, then most probably it is a type 1 diabetes. It is an non-insulin dependent insulin dependent diabetes mellitus. Then type 2 diabetes mellitus is non-insulin dependent diabetes mellitus. And so here we are giving tablet metformin to combat the diabetes mellitus. Metformin is an oral hypoglycemic agent. It's a biguanide class, comes under biguanides class. And metformin, it activates the AMP dependent kinase enzymes, and it decreases the hepatic glucose output, and it also decreases the hepatic gluconeogenesis, thereby decreasing the blood sugar level. So we are giving tablet metformin 500 milligram once daily in the morning for blood glucose control. And metformin, along with metformin, to combat dyslipidemia, we are giving tablet atorvastatin 10 milligram once at night bedtime for the control of dyslipidemia. So you have to also write in prescription what is the formulation, oral formulation or IV or syrup formulation you have to write. Then the drug name you have to write, then the dosage you have to write, whether it is a milligram or micrograms or grams. Then you also have to write the frequency, and you also have to write like for how many days the patient have to take the tablet, like for 1 week or 2 weeks, or like morning, afternoon, night, when patient has to take. All these details you have to mention in the prescription. So and you also have to mention the advice, like what advice you are going to give to the patient. So for this patient, you are giving advices. He has to control the diet with restriction of sugars, oils, and he has to take more of fibers. Basically he has to take foods with low glycemic index, and he has to include more of a fiber rich foods in his diet, and he has to do exercises daily for 5 days a week for at least 150 minutes per week. Otherwise he can go for brisk walking 30 minutes per day. That also he can do, so that he can keep him healthy and he can control his diet. And you have to follow up follow up after 15 days. Like you are giving the tablet for 15 days. Then again you have to take all the blood samples, fasting blood sugar, then everything. Then you have to see whether this drug is effective or not, and you have to check whether there is a decrease in the blood sugar levels or not, and you also have to acknowledge the compliance of the patient, whether the patient is taking daily the tablets or not. So follow-up is very important in diabetes, because sometimes the patient, this dosage may not be enough for his sugar level, so we have to increase the dosage. If the patient is not on follow-up, and if you are giving a lesser dosage, and if the patient diabetes is not controlled, then he might land up in complications, microvascular and macrovascular complications of diabetes mellitus, which is diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy. So physicians should take utmost care for the diabetes patients to keep them in follow-up, like once in a month or every 15 days, or whenever you have prescribed a newer drug. Like whenever you prescribed a drug for diabetes, you have to check the efficacy, whether it is effective in controlling the blood sugars or not, by regular follow-up. Otherwise there is no use. Then finally you have to put your signature and stamp. So this is how you manage a case of diabetes mellitus with dyslipidemia. Then case 3, 57-year-old male patient named Manohar Lal from G17A South Extension. He comes to the emergency department with retrosternal chest pain not relieved by rest. In the past, he had suffered few episodes of chest pain on physical exertion lasting for 2 to 5 minutes, which are relieved by rest. So he was having a few episodes of chest pain, anginal pain, and which is relieved after a rest. And now he has come with retrosternal chest pain not relieved by rest. He has a history of hypertension for 7 years. So he is a hypertensive patient for the past 7 years. And for the hypertension, he was advised hydrochlorothiazide, which is a thiazide group of diuretics, 25 mg daily. He was on thiazide diuretics. And on examination, his heart rate is 82 beats per minute, and his blood pressure is 160/94 mm mercury, and respiratory rate is 16 per minute. So write the management plan for him. So this is the prescription. What is stable angina and unstable angina? Stable angina is the patient is having chest pain and it is relieved after rest. Unstable angina is the patient is having chest pain on exertion or something, or he is having continuous chest pain which is not relieved by rest. So here the patient presented with unstable angina. So this prescription, they have given aspirin 300 mg per oral, 1 tablet stat, and nitroglycerin 0.5 mg sublingual, 3 tablet, and intervals of 5 minutes. Only these 2 drugs are enough to tackle this patient? No. So this prescription is incomplete. Hence now I will show the complete prescription to manage the case. So first, whenever the patient comes to the emergency, you have to take care of his oxygen saturation. So we have to provide a supplemental oxygen which is needed to maintain the oxygen saturation. Then we can give antiplatelet drug tablet aspirin 300 mg per oral, 1 tablet stat. Then to relieve the pain, the anginal pain, we are administering the nitroglycerin 0.5 mg sublingually. So sublingual, the action will be very fast. So 3 tablets at an interval of 5 minutes. Or IV nitrates at 5 to 10 microgram per minute by continuous infusion. So along with aspirin we can give clopidogrel also. Then along with this anticoagulant we are adding, it's a low molecular weight heparin, which is injection enoxaparin. It binds to factor 10A and inhibits it, and thereby it exhibits anticoagulant effect. Injection enoxaparin 60 mg subcutaneous. Then we are also giving metoprolol to control the heart rate and decrease the cardiac workload by decreasing the oxygen consumption. And the patient is also having hypertension, so to combat hypertension we are giving lisinopril, which is an AC inhibitor, 5 mg per oral. Give 1 tablet stat, and We are also giving tablet atorvastatin 80 mg per oral, 1 tablet. So first, when the patient comes to the emergency, we have to administer all these drugs. So aspirin 300 mg and clopidogrel, enoxaparin, nitroglycerin, metoprolol, lisinopril, and lisinopril is an AC inhibitor to combat hypertension, and atorvastatin. So after that, advice is, so when the patient presented, we have to do an ECG and we have to see whether the patient is having a myocardial infarction or not, any other ECG changes, ST segment elevation and all those things. Then every 15 minutes we have to take the ECG for at least 1 hour. Then we have to do the cardiac evaluation, echocardiography. Then we have to monitor his BP continuously, whether it is rising or decreasing. Then pulse oximetry to see the saturation. Then at the same time we also have to measure the urine output, and we should make the patient to be at rest. He should not exert. If he exert, the pain will increase and it will worsen the situation. Then we have to do some investigations, troponin T or I at the time of presentation, and we also have to do the other tests like CBC, prothrombin time, PTT, ABG, LFT, RFT, chest X-ray, echocardiography, lipid profile, blood sugar. So all this metabolic profile also we have to do whenever the patient presents to an emergency with unstable angina. So case number 4, 57-year-old male patient Manohar Lal from South Extension presents to the emergency department with the onset of severe retrosternal chest pain associated with the diaphoresis. Diaphoresis is profuse sweating. So the patient is presenting to the emergency with retrosternal chest pain with profuse sweating. The pain is radiating to the neck, shoulder, jaws and down to his left arm. It is a typical presentation of acute myocardial infarction. So the patient is having the pain and it is radiating to the jaws, neck, shoulder and down to the left arm. So it is a typical presentation of acute myocardial infarction. He has a history of hypertension for 7 years and was advised hydrochlorothiazide 25 mg daily. On examination, his heart rate is 82 beats per minute and BP is 160/90 and respiratory rate is 16. Respiratory rate is normal, whereas the BP is elevated and heart rate is little bit elevated. And ECG, the patient has undergone ECG, it shows ST segment elevation, which confirms the diagnosis of acute myocardial infarction in leads B2 and B3 and B4. So now we have to write the management plan. So in this prescription they have given only the oxygen supplementation, then morphine, aspirin, nitroglycerin. This is not a complete prescription. Now I will show you the complete prescription, how to prescribe when a patient presents with acute ST elevation myocardial infarction. So first you have to provide, as I said, for unstable angina presenting to the emergency, you have to provide the supplemental oxygen. We have to maintain the oxygen saturation. Then we have to give injection morphine 2 mg IV steroid because the patient is having severe pain. So to combat the pain, we have to administer morphine 2 mg. So the pain will further aggravate the condition. So we have to decrease the suffering of the patient. So we have to decrease the pain. So to immediately decrease the pain, we are giving the morphine injection, which is an opioid, 2 mg IV stat. Then we are giving antiplatelet agents, aspirin and clopidogrel 300 mg per oral, 1 tablet. Then nitroglycerin. Nitroglycerin is a vasodilator and 0.5 mg sublingually, and or isosorbide dinitrate. And before giving isosorbide dinitrate, you also have to check whether the patient is having, if he is having inferior wall MI, then you should not give isosorbide dinitrate or mononitrate. Then enoxaparin 60 mg subcutaneous. This is a low molecular weight heparin, which is an anticoagulant. Then again beta blocker to decrease the cardiac workload and to decrease the heart rate, and it decreases the oxygen demand. Metoprolol 25 mg per oral, give 1 tablet as start. Patient is also having a hypertension, BP is 160/90, so we give lisinopril 5 mg per oral, so 1 tablet start. And atorvastatin 80 mg per oral, hypolipidemic drug. So first we have to administer all these drugs. Then we have to admit the patient in ICU, then prepare him for percutaneous coronary intervention. Then meantime we also have to monitor his cardiac status, then we have to continuously monitor his blood pressure, then pulse oximetry to see the oxygen saturation, then we have to see patient's urine output, then we should keep patient at bed rest. Then we have to do other metabolic profiles like RFT, LFT, then other hematological assays like CBC, PT, PTT, ABG, troponin, cardiac markers, chest X-ray, PAU to see whether the status of heart, whether it is dilated or better nowadays it is better to do echocardiography to see whether any clots and other things. Then lipid profile, then blood sugar. So all these things we have to monitor. So this is the complete prescription for acute ST elevation myocardial infarction. So next, so a 60-year-old male who was on digoxin for congestive heart failure with atrial fibrillation has presented to emergency with nausea, vomiting, abdominal pain, decreased vision and palpitation. On examination, heart rate is 40 per minute and ECG tracing has shown first degree AV block. Serum digoxin levels are found to be 3 nanogram per ml. Patient was on following medications: tablet furosemide 80 mg PD, tablet metoprolol extended release 25 mg OD, tablet digoxin 0.125 mg OD. So what is this condition? So here if you can see the digoxin levels are 3 nanogram per ml. So what is the normal therapeutic concentration of digoxin is 0.5 to 1.4 nanogram per ml. So it is 3 nanogram per ml. So it shows that it is a digoxin toxicity. So this nausea, vomiting, abdominal pain, decreased vision, that is patient will be having yellow vision, xanthopsia or all extracardiac toxic symptoms of digoxin, and palpitations, arrhythmias, this first degree AV block, all these are cardiac symptoms of digoxin. Since digoxin can be used for treatment of arrhythmia, but in toxic doses it itself provokes arrhythmia. So how will you manage this condition? And patient is also taking diuretics. So you all know that furosemide diuretics, furosemide what it will do, it increases the excretion of electrolytes like sodium, potassium. So patient will be having hypokalemia. Then the hypokalemia will also aggravate the arrhythmias. So digoxin toxicity will also aggravate arrhythmias. So we should not combine diuretics with digoxin. So if we combine diuretics with digoxin, patient may prone for electrolyte abnormalities and digoxin toxicity as well as other things. So to combat the digoxin toxicity, we have to give if it is in ventricular arrhythmias, we can give lidocaine. It can combat the digoxin induced ventricular arrhythmias, and generally we can give digibind. It's an antibody against digoxin. So it will also be used to treat the digoxin toxicity. So these are the prescriptions today we have seen, and next you will be seeing drug-drug interactions, which will be taken by Dr. Archana. Thank you.
Good afternoon everyone, and a very happy new year. So see, these prescriptions, they are very important. The first thing is, you're all going to be clinicians, you're all going to be doctors, and so what patient carries when he leaves your office, when he leaves your clinic, is that written prescription which you give. So that prescription should contain all the information for his reference in future. And as you already know that anything which is not documented was not there. So whatever drugs you have given, whatever advice you have given to the patient should all be documented. And the second important thing about these prescriptions in your pharmacology curriculum is that in every internal or say final professional examination, in your practicals you will get these prescriptions. You will get to write a prescription, you will get to audit a prescription. And so if you are thorough with these, if you write correct ones, then you are going to score good marks in practicals at least, and that won't be a big hassle for you, because for every system we take these case-based learning classes. In these case-based learning classes we essentially discuss the right prescriptions, the audit of the prescriptions, and of course rational use of drugs and drug-drug interactions. So if this would have been say physical classes which we had with earlier batches, we actually told you to write these prescriptions and then we would correct those prescriptions. But just because we are having this online system, we have already, Dr. Sarvan has already given you the right prescriptions. So try to go through these, because these classes are already saved with you. So you can try to go through these again and try to write these in your say notebook or wherever, and try to correct them yourselves. Okay, so now we will be moving with the second part, that is drug-drug interactions. So whenever you write a prescription, or you whenever you advise a drug to the say your patients, it's not only one drug which you prescribe. Many a times they come with some comorbidities, and while you will be posted in clinical departments and you will be doing internship or your MDs, you will see you are in a tertiary care center here, AIIMS. So you don't get simple patient, a patient who has only diabetes. No, you get, most of the patients you get have many comorbidities, and then you need to add drugs for those comorbidities along with a say the condition which he seeks help for primarily. So whenever you are writing multiple drugs, you need to know how those drugs are going to affect each other, whether one drug will potentiate or degrade the effect, or might cause many other side effects, or I'd say adverse effects of a drug. So whenever we are writing prescriptions, we are trying to help a patient relieve his symptoms. Now if we write say some drug which do not go with each other, then what will happen? We are causing all the more damage to the patient. So that should be avoided. So when you read about individual drugs, but then you have to pay heed to this part of drug-drug interactions as well. So we'll be taking a few cases and discussing how these drug interactions affect each other's effect. Now these interactions could be pharmacokinetic, could be pharmacodynamic interactions, right? So these terms that may sound very vast or vague, but then the thing is that what does a drug affect for the other one, whether it affects pharmacokinetics or pharmacodynamics, right? So let's take our first case. A 52-year-old patient is receiving enalapril 10 milligram per day. His blood pressure is well maintained around 120 by 80 millimeter of Hg. He now develops pain, swelling and stiffness of joints, and a diagnosis of rheumatoid arthritis is made. Now when you see, first of all, the patient is a hypertensive and he is getting enalapril for that. He now means in the course of his treatment with enalapril, he has developed some pain, swelling and stiffness of joints, and for this diclofenac has been added to his treatment regimen. Okay, now pain and swelling is now well controlled. Why? Because we have added diclofenac. But what happened is BP measurements are deranged, that is at 140 by 88. Essentially earlier, before we added diclofenac, patient was say stable or maintained with enalapril and his blood pressure was around 120 by 80 millimeter of Hg. but now his pain is controlled, but his blood pressure has deranged or has increased. So now if I intend to ask why, so if you would have been here, you'd had to answer this, but then as we cannot interact, that's why I'll give you the answer straight away. So you know enalapril is an angiotensin converting enzyme inhibitor. So it has its antihypertensive action, and that it exhibits via inhibiting this enzyme. Now this class of drugs also has an effect on kinins, that is, it inhibits the breakdown of kinins. Okay, so what? Now what does kinin do? Kinins stimulate production of prostaglandin. Now here what we are doing is, ACE inhibitors are there, so their antihypertensive action is exerted partly by inhibition of kinins, those kinins which stimulate the production of prostaglandins. Now what was the other drug we gave? That was diclofenac. That was an NSAID, non-steroidal anti-inflammatory drug. Now these drugs function by reducing formation of vasodilator and natriuretic prostaglandins. So what happens is, this is reducing the formation of prostaglandins. So what will happen is, ACE inhibitors, now that is increasing production of prostaglandins, and NSAIDs, they are blunting the, or say reducing the effect of prostaglandins. So altogether what is happening is, action of ACE inhibitors is getting blunted. So if the action is getting blunted, what is happening? It is normal, we will get a higher blood pressure. So now the patient who was stable on ACE inhibitors is no more stable, and his blood pressure is deranged. So now if you say withdraw this drug, if you withdraw prostaglandin, so what will happen? Say over a course of time, the blood pressure will again come to normal. Second thing is, now second question, that is, a patient of congestive heart failure with atrial fibrillation treated with digoxin 0.5 milligram per day complains of nausea, vomiting and blurring of vision. His ECG reveals bigeminal rhythm. These symptoms occurred shortly after hydrochlorothiazide was added to his regimen. What is the possible mechanism of this suspected drug interaction? Okay, so here this patient, a patient of congestive cardiac failure along with atrial fibrillation. So for this condition he was being given digoxin, that is 0.5 milligram per day. And now what happened is, we added hydrochlorothiazide to this regimen of digoxin. After that what we saw was, his ECG reveals bigeminal rhythm, and he also complains of nausea, vomiting and blurring of vision. So what might be the possible cause of bigeminal rhythm? So as you all have studied this, that diuretics like hydrochlorothiazide, these cause hypokalemia. This reduction in serum potassium, these levels, what do? They increase the risk of digoxin toxicity. Thus potassium and digoxin, they both of them inhibit each other's binding to that sodium potassium ATPase. Okay, so they are in competition with each other. But what happens is, when serum potassium levels decrease, that competition, that competitive inhibition effect is it is not there. Therefore what happens is, hypokalemia facilitates the drug actions, and that can precipitate arrhythmias which are caused by digitalis. And keep in mind that digitalis can cause any possible arrhythmia you know. There is a drug, it has this has capacity of causing each and every possible named arrhythmia. Okay, bigeminal rhythm being common. That is why diuretics like hydrochlorothiazide, which can cause hypokalemia, should not be given, or whenever given you should be cautious. You should monitor the levels. If you have no other choice and you have to give hydrochlorothiazide, then you should at least monitor the levels of serum potassium. Now this is a very common case that suppose a 56-year-old male, known case of atrial fibrillation. He was on warfarin therapy. Now he presents to community physician for complaints of sore throat and fever. There he was prescribed erythromycin 500 mg QID, that is 4 times a day, as empirical treatment. Now after 7 days, patient develops melena. What is the likely explanation for this interaction? So what is happening here essentially is, you see warfarin. What is that? Warfarin is an anticoagulant. So, and you see a patient developing melena after 7 days of erythromycin. So what is happening here? Effect of warfarin has been potentiated. Now why has that been potentiated? Because erythromycin has caused some effect on cytochrome enzymes, right, which have an effect on warfarin. So what do they do? Those enzymes, they will have effect on warfarin. They'll basically metabolize warfarin. And so what happens is, when you have given erythromycin, those metabolites, that metabolism, the process of metabolism of warfarin, that is delayed, right, or that is, say, partially inhibited. And in that case what happens is, effect of warfarin per se is potentiated. So inactive metabolites are not formed, and warfarin and its active metabolite, their effect is potentiated. So what happens is, anticoagulation effect is for a longer time, or say that effect is more intense, and what happens is, patient tends to develop melena. Then we have a 50-year-old patient who is brought with severe dizziness and confusion. He had an attack of chest pain, for which he took several tablets of nitroglycerin. His current medications include aspirin for prevention of heart attack, and he also takes occasional tadalafil 10 mg for erectile dysfunction. Now what happened after this was, his BP was 70 upon 50 mm of Hg and heart rate 120 beats per minute. Now if I ask you to comment on this scenario, so let's go backwards. Now you see a patient whose blood pressure is 70 upon 50 and heart rate 120. So of course patient is hypotensive and tachycardic. So in your physiology classes you would have read that patient, when a person is, say, hypotensive, what will happen? There would be reflex tachycardia. So now here your patient is hypotensive, and that's why he is having reflex tachycardia. Now go further ahead. There you see this patient has an attack of chest pain, has dizziness, confusion, and he had an attack of chest pain for which he took tablets of nitroglycerin. So this time the patient might know that he might have an anginal attack, or he might think that to be a myocardial infarction, whatever. So patient himself took nitroglycerin. What he did not see at the back of his mind was, he was already on a medication called tadalafil. He takes that occasionally. Now what will happen is, when a patient takes nitrates, so nitrates are then they form nitrites, then there is release of nitric oxide, that acts on cyclic GMP, and we have dephosphorylation of myosin light chain kinase. What does it do is, we have vascular smooth muscle relaxation. Now in this step we saw that when we administer nitrates, there is increased cyclic GMP, which causes the downstream effects. Now this cyclic GMP is degraded by phosphodiesterase, and the drug tadalafil, that is phosphodiesterase inhibitor. So what happens is, when cyclic GMP is not degraded, it of course accumulates, and when it will accumulate, what will happen? It accumulates, it will cause more downstream effects. And what is the downstream effect of this is vascular smooth muscle relaxation, and as a result what happened is that blood pressure of the patient fall back, right? It has fallen, and what happens is patient went into a dizzy and a confused state. Okay. So nitroglycerin releases nitric oxide, which intracellularly increases cyclic GMP. This leads to vasodilation. Tadalafil is a phosphodiesterase inhibitor, and it reduces breakdown of cyclic GMP. Now both of these combined together leads to marked vasodilation and precipitous fall in BP, which can be, of course, patient is dizzy and confused. If BP falls further, it can be life-threatening for the patient. Next, a patient with acute congestive heart failure was being treated with furosemide. On stabilization of his condition, therapy was switched to spironolactone. Patient was well maintained on this therapy for 6 months. When he showed progressive worsening of symptoms, his physician decided to add enalapril to his regimen. What are likely outcomes of this change? So here you see that patient was a patient presents with or has symptoms of acute congestive heart failure, acute CHF. He is being treated with furosemide. Now after a period, physicians checks the patient, one of you check the patient, and you tell, okay, now we do not need furosemide any further, we switch the patient to spironolactone. Now it is fine, okay, the patient does well for the next 6 months, but then he has worsening of symptoms. Now you decide to add enalapril. So is it fair for the patient to add enalapril to the regimen of spironolactone? So you all know spironolactone is a potassium sparing diuretic. What does that mean? It means that it can raise serum potassium levels, right? Now you are giving ACE inhibitor like enalapril. So what can this do? This can also increase serum potassium levels. So both the drugs, now they are raising serum potassium levels. So what will happen? There can be dangerous hyperkalemia, muscle weakness, bradycardia or cardiac arrest. There might be many types of arrhythmias because of this. So this choice of adding enalapril to a regimen of spironolactone is wrong, should not be added. It is not rational. Next, a 45-year-old female patient with stable angina is being treated with atenolol and aspirin. She reports that her symptoms have worsened over past few weeks. What is atenolol? It is a beta blocker. Her physician adds verapamil to her existing prescription. Several days later, she presents to the emergency department complaining of dizziness. Her BP is 100 by 70 mm of Hg, heart rate 40 beats per minute. What can be the most likely cause? So now, to get a clear picture, we have a patient with stable angina who is on beta blockers. Now when we see her symptoms worsen, she is not being maintained further by beta blockers, we have added a calcium channel blocker to that. That too, we have added verapamil. Okay. Now the patient presents dizzy. She's of course you can see she is hypotensive, and she has bradycardia, and also she is dizzy. So verapamil or diltiazem, both of them, these are non-dihydropyridine type of calcium channel blockers. So these have a depressant effect on heart. Now a combination of these drugs with beta blockers may produce atrioventricular block, and further there is depression of ventricular function. Here you see, just because there is depression of ventricular function, there is atrioventricular block, you can see you have decreased BP, decreased heart rate, everything. And then suppose in this case patient already on beta blockers, we add nitrates. So what will happen is nitrates are a better alternative in this case, because they don't depress the reflex mechanism. So there they can have reflex tachycardia. Right. Then I think this is the last one. So a hypertensive patient was well maintained on propranolol 160 mg per day for several months. He went for routine ophthalmological examination when he was administered phenylephrine eye drops. Soon the patient complained of headache, irritability, confusion, and he had an altered mental status. Explain why. So this patient already hypertensive and taking propranolol say for several months, let's assume 6, 7, 10 months, whatever. Now he had to do a ophthalmological examination. Now there he was given phenylephrine. You already know that this drug is required for ophthalmological examinations when you don't want to have cycloplegia. Now when this was given phenylephrine, the patient complains of headache, irritability, confusion. So why? Now when you gave phenylephrine, what happened is, cause there was a marked rise in BP due to blockade of sympathetic vasodilation affected by non-selective beta blockers, propranolol. Due to this unopposed alpha-1 agonistic action of phenylephrine, patient suffers from a hypertensive emergency. Maybe means there is a very high blood pressure we assume. So there might be a hypertensive urgency or hypertensive emergency in this patient. Right. So whenever you are adding on, you saw all these scenario. If you see them differently, means if you see them say at a different position, that a person is a hypertensive, okay, you have given that person some drug, say a beta blocker, propranolol. Now that patient comes for eye examination. So if the two physicians, say a cardiologist and an ophthalmologist, they both should see the patient as a whole. Right. The diseases, they are not mutually exclusive from each other. Right. And likewise, drugs, they are not also mutually exclusive. When you give one drug on one system, so suppose it can have a beneficial effect on one system, but then it can have a deleterious effect on other, or say all others. So never ever try to treat the disease. Keep this in mind that you have to treat the patient. So whenever you see a patient in your say future days, in your clinical postings, in your internship or residency or anywhere, you should take full history of the patient, and that matters a lot. Right. You should see full history, you should see full disease history, you should see full medication history, and then you can combine and make ends meet so that patient does not get harmed by your medications. Right. So I think we'll end here, and keep in mind that these things, there will be your questions in your practical examinations, be it internals, be it professional examinations. So just a little bit of attention to these can get you good marks or score you say maybe full marks in your practical exams. Thank you very much.
बात करेंगे भाई से अपने